there are many reasons to believe there is a difference. First, they share different platforms, even though they might be the same brand, but they're completely different platforms. And two, there are two different settings. One is in the OR, with viscoelastic in, pupil dilated, and the other is on the slit lamp. So basically, we set out a study to investigate that. It's a prospective study, IRB approved, performed starting June 2017. One surgeon, myself, one center, using the Zeiss IOCT system, intraoperative, and following the patients for 3 months, day 1, 7, 30, and 90 days. We looked at the OCT vault before and after viscoelastic removal. Then the first day and so on to 3 months using also the Zeiss Service OCT. So an important thing to know that the IOCT does not have calipers. So in order to determine the true volt, even though you could have an idea postoperatively how much is the volt, 700, 800, you can have an idea, but to know exactly for the sake of the study, we had to wait till we have measurements postoperatively, get the ICL lens thickness postoperatively, and go back to the IOCT intraoperative measurements, and using the ICL now thickness as a caliper, try to extrapolate the volt OCT using third-party software like AutoCAD or ImageJ. Another important thing to mention is that you cannot use the wide-angle mode of the IOCT. That's going to give very aberrated, distorted images, just like you see on the right-hand side, just like a GoPro camera. If you use the wide-angle mode, the 170 degrees, it's going to give you very distorted, not real images, and you cannot take those measurements. So instead, you have to go to the lowest mode possible, and then, as you see on the right-hand side, you can get real-life or distortion-free images. So basically what we noticed is that the volt decreases by about 175 microns before and right after you burp the viscoelastic out. And from that post-viscoelastic removal to the first day, there's another decrease of about 80 to 100 microns, and it's consistent basically throughout the 3-month follow-up. Like Christophe had said, we noticed that the volt is kind of stable. Now looking at the blend open plots, we noticed that intraoperative measurements compared to the post-operative at 3 months, it was higher by almost 80 microns systemically. And then the 95% confidence interval limit of agreement, was all the way up to 200 microns and all the way down to -50. You could see that there are 2 outliers over there, but overall, most of the measurements were smack in the middle zone. The Pearson correlation, by the way, was also very high, 0.962. So, in addition to the intraoperative OCT, in addition to be very friendly to your coronaries, basically I assume there are 3 major advantages here. One, if you see extreme volt, like really almost no volt, like here, a very high volt, you have the option to explant the lens right on the operating table. 2, and this is the discussion, if you're inclined to perform bilateral surgery, and this is what would be great for Dr. Christophe, I believe you can proceed with the other eye if you judge that the OCT in the first eye is good. Also, my concordance rate evaluating all my ICLs is about 20%, meaning that most lenses will fall within 20% volt, and that would be a good reason to move to the other eye. Now, finally, OCT has been the fastest growing imaging technology in the history of ophthalmology. 25% of all diagnostic measures in ophthalmology is by OCT. What's the likelihood of that technology being adopted widely 5 years down the line in the surgery, in the operating room? For me, it's very high. But what's the likelihood of us discovering a magic formula to predict volt post-operative the ICL? Not so high. So basically, for me, I suggest to have a package containing 3 lenses. The volt we want, up and lower. Basically, if you think about it, there are 3 major complications, let's say issues with ICL, right? They're rare, but they're the 3 most important. STAR has eliminated 2 of them by just introducing the central flow. So one was the cataract, and two, the acute closure. The third one, which is now the last frontier of the issues with ICL, is basically the exchange rate post-operatively. So now, if we have an adequate OCT that would accurately predict the post-operative old, that will be completely eliminated. So for this, OCT should be, one, reliable, and two, it should be predictive. And based on our initial assessment, I believe it is. Thank you.
Much about the same thing, IOCT intraoperative.
Thank you, chairpersons, and good morning, friends. Indeed, it's been a pleasure day for me in a beautiful city of Vienna. Can I have a slide, please? And thank you, Star, for giving me